Welcome, everyone. This is our third webinar in our series concerning every issue around ambulatory surgery centers. So welcome. We're going to discuss bundle pricing and talk about the value that it brings to facilities. My name is Dr. Paraj Patel. I'm the founder and CEO of preferredMD Solutions. Today, we have a wonderful host of people joining us. As our speaker, we're going to welcome Dirk Carson. He's the principal at Carson Consulting Group and comes with a wealth of knowledge. Introduce yourself, Dirk.
Good afternoon, everyone. Thank you, Dr. Patel. I appreciate the opportunity to be here today. I have been working as a consultant in healthcare for a lot of years, but the last 8 years have been really pretty much exclusively focused on value-based care. So bundles play a big role in that, and what we're going to try to do today is to sketch that out for you so you can get a better understanding of the stakeholders and functionality and how they are playing out in the market. So thank you again.
Great, thank you, Dirk. We're also joined by our panelist, Becky Ziegler-Otis. Becky is an administrator, or was at an ambulatory surgery center, and has great experience using bundle pricing.
Thank you, Dr. Patel. My name is Becky Ziegler-Otis, and I actually worked as an administrator for 13 years at an independent multi-specialty startup surgery center in central Wisconsin. And during that 10-year time, I did have the opportunity to work on bundle payment strategies with Dirk, ironically. So we have a bit of a relationship there. And so that's where I got my feel and flow into the bundle patient strategies for ASCs.
Wonderful, thank you. And we have Ashley Poulos, who is my favorite ambulatory surgery center administrator, who really doesn't have too much experience with bundle pricing and would like to learn more. Ashley,
Absolutely. Dipped our toes in it a little bit, and we're definitely ready to go in that direction again.
Right.
I think the first question is, what is bundled pricing? To get right into it.
And that's the foundation of where we're going to start. And there are a lot of attributes to bundled pricing. We're going to touch on most of them as we work our way through the presentation today. But at its foundation, it is a financial arrangement that puts all of the included elements of a particular procedure. Let's just call it a total knee. So we're going to bring together the facility. We're going to bring together the anesthesiology. We're going to bring in the surgeon. We're going to bring in the implants, all of the attendant costs to a traditional approach to that surgery in one episode, in one bundle. So we can set that definition on what's included and what's excluded, and then use that in order to set a market price or come up with a market price that is effective and sustainable. And at least equally important, this cannot be a race to the bottom. This is about setting what the benchmark should be for cost of care, as opposed to trying to drive down the price of the services to the point where we have to take pieces out of it that make it ineffective. This is really about how do we provide the sustainable pricing, the reimbursement that individuals need, but also that we can, the individuals meaning the provider community, but also in a way that we make it affordable for employers. We'll talk about that a little bit more as we get through. But how do we bring all of those services together in a way that serves both the provider, the employer, and especially the employee, that patient that's so important to all of us.
So it sounds like it's more directed towards providing excellent healthcare rather than the cheapest healthcare.
100%.
Right. And fixing the issue, fixing the condition rather than a fee for service, i.e. the more service you provide, the more fees you get.
Yeah, we're going to talk more about that too, but absolutely 100%.
All right.
This is about a reasonable pricing for a set of services. It's also about, in I don't want to get too esoteric here, but in one sense, we are helped by the current system where we have defined things in terms of ICD-9s and CPT codes. That gives us a starting place. But once we get that starting place, then that becomes more of an anchor for us that we need to jettison. We need to be thinking in terms of, from a bundle standpoint, when I open the shoulder, I may have a total, I may have a partial, but almost anything else that I'm dealing with should be pretty much under one umbrella. I don't want to have to open it up and say, okay, no, this is this CPT code and not that CPT code, and therefore it's not a bundle, it's a this or it's a that. We want to be able to say it's a shoulder, folks, and we want to price it accordingly. Meaning, let's just say that you have half the time you have a minor debridement, the other half the time you do significant debridement. Fine, we'll take that, cut it in half. We'll pay the 50% rate in between the two of them for every single surgery. And now you don't care, I don't care, because over the course of time, it's going to all work out for everybody's purpose. But in a much more simplified, much more understandable way.
And does it get to the point where surgery centers have that volume that justifies the medium between the two?
Yes, absolutely.
Okay.
I mean, that's the goal, right? So that if it doesn't work out over time, and that's something that we can study too, right? I mean, you're still going to have some of these, still going to have the medical records from what's happened. If there needs to be true-ups at different points, or we need to move the needle one way or the other in order to make it more attractive or more sustainable, then that's what we do. The beauty of this is it's more like the Wild West. I mean, we have to convince our clients, okay, typically self-funded employers, that this is a good deal for them. And there's not a lot of convincing that has to go in that, and we'll get to the reasons why shortly. But we don't have to be beholden to what the Millman rule set is, to what CMS's rule sets are. We have to practice good medicine, but we don't have to have the structure around it that complicates things and makes things more difficult.
And I would say that Dirk is explaining that very well. But Ashley, when you talk about, do surgery centers have that wealth of data? One of the things, and you'll get into this in a few moments, is about using different TPAs to help you with this. Now, not all of them are as creative and as open-minded to work with as some. And so I would tell you, looking at it, do you have the depth to determine if some of them are, going to have debridements, and how to price that out? They're all not the same. They're not all created equal as far as who you're working with. And that's important when you're establishing that relationship with whoever you're going to do the bundling with.
Okay. It kind of backtracks. There's been a few things like the TPA and some other things like self-insured. Is there certain terminology that we should be familiar with when working with bundled pricing?
Absolutely. And that's a great question, Ashley. This is healthcare, of course, so we have all acronyms all the time. And so in the insurance world, in the healthcare reimbursement world, we have public and private, or we have government funded, and then we have what we would refer to as commercial insurance. In the commercial insurance, that's bifurcated in self-funded or partially self-funded versus fully insured. When you think of the BUCAs, which is the Blues and the Anthems and the Uniteds of the world, Aetnas of the world, those you'll typically think about those in an insured basis. That means that you write them a check, your premium every month, and then for that period of time that you're covered, you receive your insurance. You have all of your care covered based on the policy that you have. The other side of this, which is the self-funded side, is an employer, and on the commercial space, they actually pay most of the bills. So it's an employer that has chosen to, we'll just use self-funded as the idea, has chosen to pay all of their claims for their health care rather than put the risk on an insurer. They're taking the risk on themselves. Now, if you're a manufacturer or you're ABC Supply or you're any even financial services company, well, that's not what you do, right? You don't pay claims. So there's a group of companies out there called third-party administrators, and that's TPA. So third-party administrators are the team or the company that you hire. They work with you from an actuarial basis to help set your plan design, help you do the things that an insurance company would do, and then basically they pay your claims on an ongoing basis. The advantage of working with a TPA versus a fully insured program are many, but one of the key ones is you can craft your plan the way that it makes more sense for your employees. One of the examples that I've used in the past is banking. Banking is really about two classes of people. You typically have women of childbearing age, and then, excuse the expression, you've got a bunch of old white men. So I don't mean that to be as un-PC as it sounded, but so the fact is, what you really want your plan to do is to incent things like prenatal care. You want to have prenatal vitamins. You want to have well baby care. You want to have a plan that's sort of skewed towards supporting the women that are giving childbirth. At the same time, you also want to have things like cancer screenings and other types of care that will support that older demographic. Whereas you're probably it's not as important to have things like the weekend warrior orthopedic benefit, because you're going to have fewer people out there that are playing softball at 25, 35. So that TPA allows you to craft that plan. They also are very, very supportive of bundle community. So they are the ones that are, in a sense, responsible to that employer for the cost of care that's being delivered to those employees, being paid for by that third-party administrator. Does that make sense?
Do you think a lot of employers go the direction of a TPA?
All larger employers do.
Okay.
It is very rare to see one that doesn't. Now, just to be fair though, or to be more descriptive, United Healthcare offers TPA services. Anthem offers TPA services. So that's just the form of the service that they're providing or the risk that they're taking or not taking. But yes, every company that's over, I shouldn't say every, the vast majority of companies that are over 500 will be self-funded. A preponderance then between 1 and 500 will be self-funded. Just that you have a lot more latitude in there, and there's no reason to lay off that risk on an insurance company.
So, Jeff,
go ahead.
Sorry to interrupt. You'd mentioned that that large insurance companies offer TPA services. Now, how does the cost of that differ between the insurance company's fees and a private TPA that's smaller?
They will often be significantly higher.
I figured. Okay.
Very, very significant.
And that cost is passed on to whom?
The employer. Yeah. They'll have a myriad of fees that they have built into their.
Okay, so it's not in the employer's best interest to just use their insurance company as their TPA.
It bears excuse me, it bears evaluation, but only in the context of looking at what's available to that.
Okay, that makes sense. So what's an episode of care?
Let me touch on a couple of these other things first, if that's okay with you, and
Sure.
come back to the episode of care instant. So most of the insurance, whether that is self-funded or through an insurance company, is sold by a broker, another term that we have here. And that broker represents the interests of the company, but they're also paid a commission to place stop loss, which you have on the self-funded side, partially self-funded side, or they're paid a commission and overrides on the fully insured side. So there's a significant financial incentive for them to pony up to the BUCAs, the insurance company.
Okay.
One of the other players in this is direct to employer, or otherwise known as DPC. That's going to be on-site and near-site primary care. And those play a critical role in the success of getting members to the bundles. And the reason is, if you think about it, and we're all creatures of the same habit, I think, if you're told by your primary care doctor that you need to see a specialist about your knee, you go see that specialist and you have somewhat of a relationship with them. It's new, but it's a relationship. If at some point then you come back and now you're told you have to go to some other entity to have another consult, that just creates friction, and it's not a good patient experience. So if we educate the DPCs and DTE providers, what we do is we get that initial referral to the consult with the individual who can provide that bundle, so that there's a continuity there that doesn't exist if you don't do it in sort of that step order. Episode of care. So I mentioned early on that the bundle was a financial arrangement, and that is what it does. It does a great job. It's a great starting place for making change in the market. But a lot of what we're seeing is people that are combining that with clinical pathways. So you're working with your individual group, your provider group, to establish, well, what's the protocol for that particular service? What are the 10 things that you need that patient to do before the day of surgery? A real common one would be the couple days before they want them to use an antimicrobial, like a HIPAA cleanse. Nobody wants their patient showing up, frankly, without using HIPAA cleanse, because it makes such a significant difference to the outcome of the surgery, the potential for wound infection and those kinds of things. So I'll describe one of my clients has a care pathway that's included in it. They use a red, green, yellow light, and then they have people who monitor those, a concierge team. And if that individual continues to do the things that they're supposed to do, it comes out green, and off they go. If there isn't, then there's manual intervention. Somebody picks up the phone and calls them. Is there a problem with the HIPAA cleanse? Can't afford it, don't know where to find it. How can we help you figure that out? On the back end, they do things like, are you getting to your physical therapy appointment? If they report a 3 pain score in the morning and a 9 at night, they're on the phone within 6 minutes. We know what's going to happen. They're going to end up in the emergency department. That's a guarantee. Now, is that the right place for them? That may very well be, but let's find out. Let's get a nurse on the line with them. Let's talk through it, make sure that we understand, what they're going through. In one of our clients in South Carolina, we've been able to reduce the emergency room visits in maternity by 50%. And you would talk about your numbers. We're running over 1,200 maternities so far this year. So we've got a lot of data that help us understand what's going on.
Amazing. A lot.
It's a big group.
And I know we're going to talk about episodic care a little bit further down as well, as far as from the beginning to the end. But before that, how does bundled pricing factor into the insurance environment right now?
So I happen to be sitting in a hotel room that's connected to a casino. And so I'm going to use this analogy. The deck is stacked against us. We're in a position where the incumbent health systems, the incumbent payers have pretty much of a détente. They like what's going on in that system. That really discriminates against the independent provider. Health systems don't want to do bundles because they don't have to. They want that fee for service. They are designed for, they are aligned for that fee for service, put more in, get more out. Even the physician compensation now is almost all driven by activity, meaning the more services that they provide, the more money they make. And the hospitals are checking every single box rate. You make a referral outside of the system, you get dinged. If you didn't make those 5 referrals on this type of a diagnosis, you get dinged. So it really is, the game's rigged. And so the problem with that is, as I mentioned before, the employers are the ones that are paying most of the healthcare bill for the commercial community. Well, we now have high deductible plans. We now have copays. We now have deductibles to the point where there really is no more room for that individual for that company to have those individuals pay more. I just heard an employer talk a little bit before. I said, yeah, I mean, we couldn't recruit drivers for our company because our deductible was $1,200 and they couldn't pay the $1,200. I mean, they just, that thing, end of healthcare for them. So they start looking inside, what I call inside of the health plan. Are there ways that we can save on the things that we're already purchasing if we purchase them in a little bit different way? And bundles are a perfect opportunity to do that. And it doesn't require that the individual make less money, and individual meaning provider. In fact, most of our providers are paid better in the bundle environment, frankly, than they are in other insured environments. And why is that? Because we changed the site of service most often. We're working in an ambulatory environment. We're working in, well, let me think, an ASC, right? So we move it from the 4 walls of the hospital or the hospital outpatient, I don't care either or, into an ambulatory surgery center. The patient experience goes through the roof. All of the information that we have, all the data that we have suggests that they have a better experience as it relates to infections, rehospitalizations. All of the quality measures that you would look for are far improved. And the employer is seeing a delta of 30 to 50% over what they would pay in a hospital system. So in a lot of cases, in fact, in almost all cases that I'm familiar with, the employer is paying 100% of that cost. So the ASC isn't even having to chase the money from the member. They're not having to say when that member shows up, give me your credit card. No, it's 100% paid by that third-party administrator. So there's no chasing dollars. And what that translates to, and all of you who are on here, and Ashley, I'm sure you know your numbers. Becky, I know you know your numbers from before, but you have an uncollected debt amount from your traditional fee-for-service basis. Not here. you get 100 cents on the dollar. And you get 100 cents on that bundle that you have arranged for.
And then this kind of ties in down the road, but since you asked or mentioned it, typically how long does it take for the facility or the physician or that bundle payment to actually be paid?
14 days or less. We're working toward, again, one of my clients. In 2024, you will not send a bill. In 2024, we will be able to scrape your EHR, because think about it in these terms. If I'm fee for service, I need to capture all of those fees, or at the very least, as those fees come in, I'm going to pay them out in 30 to 60 to whatever. In our world, all I really need to know is that base procedure happened. So I need to know from your ASC that the total knee that we had scheduled happened. And you have the medical record that says it happened. Well, we have the technology to come into that medical record, see that, pull it out, use that as a funding request mechanism, and then pay you. So we can make this turnaround almost real time.
You'd mentioned that the 100% of the cost is used to cover the service of the bundle, right? The bundled fee. Now, what portion of that would go towards the administrative costs of a private TPA or someone who is managing this service?
The provider is going to get 100% of whatever that dollar amount was.
Sure.
So if we negotiated a total need at $30,000, then it's going to be $30,000 that's going to come back to the administrator. To the provider. A nuance to this, which is worth noting, and I appreciate you bringing that up, Dr. Patel, is the TPA is going to charge you to adjudicate one claim for that bundle. In the other scenario, they're going to charge you essentially a claim fee for every single claim that hits as a function of that total need. So there's even an administrative savings that happens on the inside for the employer because of the bundle structure. It really is, there's just so many nuances, but so many really good things that happen as a result of that it really is what we're seeing in terms of momentum in the marketplace.
See. Amazing.
But this is just part of the whole episode of care, correct?
Yes, very good point. So I alluded earlier to the fact that we're following that patient in one of my clients on the front end, right, from the time that they register until that day of. Our episodes will run up to typically 90 days, but in the case of maternity, it's 11 months. We're following all the way through pregnancy, post 60 days. And in some cases, if we're talking about episodes that are diagnostic in nature, we may be looking at something that runs for a year. So if we're working with somebody that has diabetes, somebody that has asthma, those are going to be much longer in duration. But you're right, and thanks for this slide. So you pick up the pre-op consulting. That's where it starts. That whole workup is included. And this is where it gets important to define the inclusions and exclusions. Because what we're doing is we're pricing for the inclusions and we're avoiding the exclusions. So in order to set the price properly, and this is always where I start with providers, is what is the service that we're going to provide? With Becky and her team, we spent a couple of months really looking at what are the services that are included. Now, we were growing it from scratch, which we wouldn't have to do now, but we have more of a checkbox approach that we can get you there with. But knowing what's included becomes instrumental in assuring that we've got the right reimbursement structure that's tied to it.
But for an ASC, as an administrator on the ASC side, we only have to worry about what's included for the surgery itself.
That's, yes, correct. We have situations where we have had ASCs where there is physician ownership that have taken on a single signature for the facility and for implants and for the surgeon. We do have some situations where there are employed anesthesiologists, and in that case, they can do that as well. But it's not a requirement. What we can do is build on each of the elements. If you, as an ASC, want to get into the game, we can help work with who your referring docs are, who are the physicians that work out of your facility. We can sit down with them. We can work through what the mechanics of what they need to do. We can talk to the anesthesia group. We can talk to the implant folks. We can talk to physical therapy if that's it on the backside. We have the ability to bring all of those entities together. So maybe it's 5 contracts, maybe it's 6 contracts that the bundle builds up to, but to the payer, to the employer, it looks like one.
Okay. And would it be separate payments that go out, or is it typically one payment that has to be divided out from the surgery center level?
Yeah, again, a great question. Typically, we would do it individually, but we can consume 5 claims and send 1 bill. We can consume 1 bill and send 5 payments. And you have to have the flexibility to be able to do that. Most providers are not equipped to divide the money and hand it out among the providers. Some of our ASCs like that reminder of their value added that they get when they hand a check to Dr. So-and-so. And so they're willing to take that role on, but by and large, that doesn't last very long because it's work, right? And then if there's ever a snafu with a payment, they find out themselves in the middle and just have to, it's just more work than they want to get involved in.
So that's interesting to hear, Dirk, from that perspective, because we had a model of one payment.
Yep.
So we had a contracting entity. It was like a shell company that actually had everything folded up into one. So we reduced the administrative responsibilities on the provider's office, the anesthesia provider's office, and the facility. It was just all in one area. And so because we did that, having it all in one area where we administered, please pay us, and then we received the money back and dispersed it, it made it cleaner. And that was actually appealing in this scenario for the surgeon's office and the anesthesia provider, because they didn't have to deal with any of that hassle. It was all included.
The other thing too, that where this comes to play in the type of structure that Becky has is risk mitigation, right? So the contract was held by a third party that to which the facility and the physicians were party, but they were not that party. So if something went amiss from a legal standpoint and there was a lawsuit, now I get it, everybody gets sued. It's a massive dart throw. But the 2 entities at the center would be the third party entity that they had, as opposed to being the front line where the facility is representing the services specifically of the anesthesiologist, let's say, or of the surgeon. So there is a line of demarcation that happens in that structure as a result of that.
How does it work?
I'm not an attorney. I only play one on TV. So, get your own legal counsel on this, but that's been our experience.
How does it work if a patient's having a procedure and it's through a bundle payment, but then they have to use their regular insurance? Say they had to have continued care in the hospital for some unforeseen reason. Is there ever any issue of coverage for the patient at that point?
Typically not. I talked about how the third-party administrators embrace this, the bundle mechanism, and the fact that the insurance companies generally don't. But we're working with a number of companies that are self-funded, using Ebuka as a TPA, but also use our services. And in that case, what happens is they pay us, we invoice them, they write us a check for the services, we distribute it to the providers. In the event that something were to happen untoward, then it would fall to the individual's insurance company, their base insurance, to cover those. Now, I'm going to give you a but. As of June 1st of this year, the Holista, the other client that I'm keep mentioning here, actually has an underwritten market warranty, so that if something went untoward with a bundle that was under their umbrella, all of those services up to $100,000 would be covered under that policy, so that it would not drop to the insurance. It also wouldn't drop to the individual's plan for them to have to pay for it. It would drop to that policy where all of those costs would be covered.
And that, I guess also protects the providers, because they are guaranteed of the additional payment in the event that there was a misstep or a complication.
100%. So we ask the providers in our contracting, we ask the surgeon in particular, if there's something that happens that can be taken care of in your office in the first 90 days during the global period, if you will, that be part of the bundle. If something goes beyond that, yes, we want everybody to continue to be paid. We want the surgeon to be paid. We want the facility to be paid. We don't want this to be a charity thing that happened. Things happen. It is relatively infrequent in the ASC environment, but it still happens. And so we're there with an insurance policy that's underwritten for $100,000 for that very purpose.
Right.
So, go ahead.
No, go ahead.
I was just going to say, I'm one of the things that I really like about how this plays out is we can track the outcomes. We can track any input we have, we can track and provide back. So we provide that type of data back to all of the ASCs, back to all the stakeholders, so that everybody can see. It's all about the light of day shining on it, so that there aren't, unlike your current healthcare company, insurance company, we're going to show you everything. You'll get to see the claims. You'll get to see all of the transactions. You'll get to see the outcomes that are a result of this. You'll get to see what type of interventions are done. You'll get to see how all of those pieces come together. And interesting enough, Holista has a 98 Net Promoter Score. What that means is that almost every single patient that goes through that would recommend them to friends and family. So their experience is so much better than they're getting in other environments. But we can only do that. We can only tell that because we're tracking.
So it's just tracked and then provided back like in a reporting style, just so that
dashboards. Yeah. You have a dashboard you can log into. The physician has a dashboard they can log into. The employer has a dashboard they can log into. So within the confines of HIPAA, of course, you can all have access to that data, so you can see exactly where you are and exactly what's going on.
it just seems that the outcomes are all kind of hinging on the fact that every stakeholder in the care of this patient is interested in resolving the medical condition. They are interested in completing the episode.
That is 100% spot on, which is different than I need to provide more services so I can drive more revenue.
Right. And I think the motivation here for the provider is, hey, I just need to fix this patient and make it all better so I can move on to my next patient.
So I can move on to my next patient. And so the patient can get to the mailbox to get their mail.
Right.
So that they can walk the dog around the block. I mean, this is about getting them back to their functional life.
Right.
With still money in their pocket.
Right. And without the out-of-pocket of the deductibles, the co-insurance, the unknown. I mean, even being an educated consumer of healthcare, I'm still confused as to what bill I'm going to get next. And that's a big deal for most people, you know?
As you know, if we've talked, I live and breathe this. I still get bills sometimes that I look at and go, what the heck?
Yeah. Wow.
Like, where did that come from? You dig deep enough and usually I'll be able to figure it out. But it's like, I can't imagine not understanding the system as complex as it is and getting that stack.
And have you ever been able to have the question answered, how much will this cost me? And the answer is, well, we'll wait and see after you've had that lovely meal at the restaurant. And then you'll find out afterwards how much it is, rather than
to see how many codes are billed and then what you do.
And then
for a straight answer.
Actually, we have a co-insurance. So really, I should know before because I have to pay a percentage of that claim. So it makes no sense to me. Why are patients rightfully so upset that they don't know how much something's going to cost them?
I don't know why. I don't know how that we've trained them not to be upset.
Yeah.
I think we're going in a direction of seeing more patients upset, though. I think it's changed quite a bit in the last few years.
Yeah.
Well, they do have more of a financial obligation in this current iteration. But, yeah, so too what happens is they may have a $1,500 out of pocket or a $5,000 max. You know, if you're having a total need, you're hitting that number.
Uh-huh.
And so you really don't have as much of an incentive.
Right, but what about the smaller interactions? The
other than to say, well, the smaller interactions, but also to say that with, you'd still have it. So if there's 100% payment on the part of the company, that $5,000 stays in your pocket, as opposed to having to pay that out. So that changes that dynamic quite a bit as well.
So, Dirk, wouldn't you also say the engagement is better on the patient or the employee behalf? Because many times, and I'll let you explain this, there is a reward at the end if they go this route. Explain, and then I think you get better engagement, better compliance from the patient/employee.
So that you brought up three great things there, Becky. One is part of that episode definition, working on top of the bundle, is about patient engagement. It's about making sure that there's compliance. It's about making sure that there's the concierge aspect of this. Second thing is I shouldn't say most, I'm going to say all of the providers that I work with that are in this space understand what business is. And it's really the customer service business. They're in the business of making sure that member's experience, and they happen to be providing healthcare, but I've been partied to, laying on the gurney side, a few of these, and it's amazing to me how much improved that patient journey is when you have people who are focused on that. How you can come into that ambulatory surgery center, be treated very well, go through the pre-op things, go through recovery, and be back in your bed that night. The the people really make a significant difference with that. And I think Becky's experience in that has been terrific. What we've seen from her team at her former ASC, they know that, and it really creates a much better environment.
To kind of go back, not back to, but like as a new administrator, I'm interested in starting this up. How do we actually get started in this? Because it's a lot to take in, and I think it's hard for us to figure out what direction to go in to actually implement this system into our, our daily operations.
You need somebody who's been there. Otherwise, you'll make the same mistakes that we all made when we first started, right? I personally help ASCs. I work with ASCs, TPAs, physician groups, large employers, all of them, and it's all in the same mold. It's working toward the same thing, which is to help both sides understand the level of services, what's included, what's excluded, the decisions that you have to make, explaining it to the physician owner, explaining it to the referral physicians, making sure that we're negotiating properly with the anesthesiologist or the device or implant. So you really do. It is difficult to do on your own. I will give you that.
Ashley, I would say from my perspective, before even jumping into it, you have to really assess your situation before you put the time and the commitment into moving forward with something like this, and making sure you have the leadership alignment. If you don't have alignment from your providers, whether it be surgeon, anesthesia providers, facility, to move forward in this direction, it's going to be difficult. Case costing, you better have your case costs known so that you know how to set your accurate pricing, things of those nature.
How do you get the surgeons to commit to it and want to be actively involved?
So I think sharing with them the benefit of gaining market share, the benefit of helping patients better outcomes. If they're independent practices, sharing with them the reduction of the red tape, all of the prior authorizations, the pre-certifications. That's a tremendous amount of labor that they have to endure in their offices. And if you can reduce some of that when it comes to sending the bill out, that should be a very simplified process. Sometimes it's not even a UB or a HCFA form. Sometimes it's just a QuickBook invoice, putting something on the portal. Getting your payments back quicker. You don't have to worry about denials and appeals. And those things are very appealing to surgeons, anesthesia providers that are running a business as well.
How long does it usually take to get a whole system in place? Like, what sort of time frame should we be looking at? Like 3 months, 6 months? Longer?
No. What I usually recommend is that we start with, I'll use a baseball acronym, but a fastball down the middle, right? So what's the low-hanging fruit? What's the easiest things that you've got case costed at this point? What are the things that are known that we could introduce right now? That we can do in 30 days, literally. Then we'll work towards the harder ones. We'll start adding those additional bundle as time allows. But two, we'll also be working on understanding were all of our assumptions right? Without going out with 50 different procedures day one, did we nail the ones that we had done first? So it's sort of a walk before you fly approach, but it's been very successful. Actually, Becky and I used that with her team up there, and some of it was driven actually by member need. I'd come up with a weird case and call her and say, "Hey, Becky, I got a member that needs this. Do you think we can do that one too?" And she go, I don't know.
Of course, we can.
I'll get back to you.
Right. So it's more a phased transition. You don't just rush straight into it. Just start with the smaller cases that the cost and predictable.
Yeah. I mean, ortho's always an easy easier place to start because it's fairly well known. I think it's the best known of those specialties. But we do ENT, we do general surgery, we do pain management, we do spine. There's 150 different versions of specialties that get involved now. It's just, and we have, the other thing is we're not, we have the track to run on. We've done these. We can set up the definitions. You can plus and minus, tweak them a little bit. We price for the market, for the region that you're in, because there is regional pricing, and we need to take that into account. So there is a playbook for it. Actually, it's not having to make it up as well.
Are there certain regions that this is more popular than others right now?
Texas has a significant amount. I think you're right. The Midwest, the Oklahoma, we're seeing a lot more in upper Midwest too. Starting to see more in the Ohio area. As I said, North Carolina, South Carolina. We have some projects going on in Florida, but also in Colorado. So
How do patients usually travel when they go this direction?
I think it's really a function of how big of a deal is it, right? I mean, if you have stage 3 cancer, where wouldn't you travel to, right? If you need your, a knee arthroscopy, I may not drive more than an hour away. We have, again, most of the employers have incentives. I've got one employer that's kind of in the middle of nowhere. Actually, Becky knows them quite well. Their members actually drive 2 hours to Minneapolis for a colonoscopy.
So is there an incentive for the member to drive that far?
There is. They get it free if they drive that far. But, to Becky's point before, and I missed this as I was going through the end of it, they get it free if they follow the protocol. If they fail to follow the protocol, they go back to fee-for-service. Now, what that means to the member, sometimes in one case, we work with a group out of North Carolina or South Carolina called Novant. It's a $4,000 hit to the member for a maternity if they do not comply with the care pathways. So it goes from free to $4,000. So there's a huge incentive to go to those providers who are providing the bundled care, but then there's also a huge incentive to be compliant with the protocol. Care pathway.
Does the member have someone directing them through the whole process so that they
100%.
Okay.
From the very beginning, they're assigned a concierge. That person stays with them throughout the entire process. The only exception is if there becomes some specialty need that's more well directed by somebody with deeper knowledge in that area. They may pass them off to a nurse clinician or someone for a period of time. But there is someone with same person all the way through otherwise.
If they deviate from the plan and then have to go back to their regular insurance, does it then get billed to their regular insurance and then
No.
and then chance of being denied because there's no author X, Y, and Z?
It's never happened. I can't say it wouldn't happen, but we would certainly, if the employer's involved, the point is we don't want to penalize the provider for the non-compliance of the member, right? So we're in there making sure that the provider gets paid, and those assurances then come from the employer as well. It can't penalize you for a non-compliant patient.
Gotcha.
So I think actually we should start to wrap up. I just want to leave enough time for questions to see if anyone has any. Is there anything we want to cover here? Any challenges that we want to briefly speak about?
I have one quick question. Do you think there's ever going to be an oversaturation of this option? Or is this going to be like an overall direction you think that it's going to go? Because as an administrator, we have so many headaches dealing with insurance companies. So they'll have a procedure approved and then they deny it even though we have authorization on it. And it's such a headache for us that we're looking for new direction as far as how to handle our daily operations.
What I'm seeing from the self-funded employer community is a complete embrace of this. I can't imagine. I mean, basically, I talked about a price delta, just on that metric alone, of 30 to 50%. I can't imagine that individual, that employer wants to go back to paying 50% or 100% more. So they're going to build their plans and build their incentives so that they are structured to support the bundled community. So I see a proliferation of these. I think your biggest challenge may come from the ASC down the street that wants to, come in and compete with you. We wouldn't let them compete on price, but they may employ PT and you don't, for instance. Or maybe they've got some robotics and you don't. But it's going to be competing on medical quality and innovation, as opposed to driving the price to the ground. And we're competing with the hospital systems to move that side of service more than anything.
Got it. Someone just asked, what are some typical mishaps that facilities make when they're trying to implement it?
I think Becky was spot on with this. You really have to have alignment. You have to have alignment from the leadership on down. If there is misalignment, it will not work. And that means that you have to walk through the process. I mean, you really physically want to lay that process out and then look at, who's affected by that. How do we perform that process? And do we have buy-in by all of the folks that are along that line? And that's probably the biggest hurdle. Once you get to the rest of it, it's just aligning all the pieces. But that making sure that your leadership on down is supportive is critical.
Do you typically work with more than one bundled pricing company? Because I know, like for us, we have two different companies that we've tried it out with, and it hasn't gone too far. Like there's been hiccups, and then quickly it puts a wall up on our end. And one was we had to go into their portal and export all of the images, then send it to the doctor, and it was a lot of back and forth, which then the surgeon wasn't interested because it was so time consuming. So they didn't see the benefit. Like, is that aspect improving?
There are, I can rattle off at least a dozen organizations that are in this space right now. Everybody's got a little bit different structure to what they're doing. And I welcome them all. I mean, don't get me wrong. I think to think that we all have this 100% down and pat is crazy. So I want to see what everybody's out there doing and trying different things and new things. But to your point, what we can't ask you to do is more and different. What we have to do is to have a structure that fits into how your business is run, how your clinical process flows, so that we help enhance those two things, that we're not asking you to do something completely different. Because that's exactly what will happen, is the physician will say, it's not worth it to me, I'm not going to do it.
Okay.
And actually, Ashley, you're exactly right. There are multiple entities out there. We dealt with 3 different ones. And there are at some points in time when you just have to walk away from the entity because maybe what they're asking you to include does not make sense for you. So you've got to make sure that you've got that set right. Or sometimes they're just really all about the pricing. They're not always just as open as what Dirk is describing. So you need to understand that with the entity that you're looking at. And sometimes you can't make it work with them.
But there are a lot of options out there.
There are a lot of options.
Yeah.
And you can work with any one of them or multiple.
Or multiple. I mean,
Yeah.
So a physician can be part of multiple TPAs, getting offers from multiple TPAs.
absolutely.
So I just have another quick question. For a surgery center that has, do you have any surgery centers that primarily base their whole operations on the bundle pricing rather than insurance? And what sort of volume do they have?
We have seen a number of the emergence of a number of ambulatory surgery centers which are cash driven,
Mhm.
and all of those are built unbundled. I think it's too early to make the call as to whether or not they'll be able to pull that off. But if you can imagine your business being run on a cash basis as opposed to all of those auths that you have to do, the ones that don't get, the ones that ultimately get denied, then on top of that, chasing the money and your revenue cycle and your uncollectibles, all those things go away if you're in a cash business, right? Show up, put your credit card down, have your need done, and go home. So it's attractive in that sense, I think, to individuals. So we'll just have to see, how that plays out over time. It just, there hasn't been enough time in the market yet to really assess that properly.
Okay.
Great. Well, thank you all so much. I think we're slightly over time. So, Dirk, Becky, and Ashley, thank you all. It was a fascinating discussion. I think this idea that we just focus on providing great care, fixing whatever issue the patient has. And I think if we're focused on that goal, this is the model of healthcare delivery of the future. I firmly believe that. It puts everyone's goals in alignment. And I really value the information you've given us, Dirk and Becky, and I hope we've answered a lot of the audience's questions. If you have any questions, please feel free to direct them to myself, to Dirk, to Becky, to Ashley, to anyone on this panel. We're happy to respond and would happily get on a call to talk about the issues concerning implementing such a program at your facilities. So welcome anytime. So next in our series, I think we're going to discuss QI studies. Ashley, is that correct?
That's what we're going to go with. Yes.
Wonderful. And
Becky might be able to join us on the next one as well then.
Definitely. And if anyone has any interest in becoming a guest speaker to talk about any nuances within the surgery center industry, please feel free to reach out. We're always happy to take any suggestions. So thank you all again for joining us. And you may receive a copy of this anonymized presentation very soon in your inbox. So see you soon.
Thank you all.
Yeah.
Bye-bye.